Hello friends, in this presentation we will try to answer few frequently asked questions regarding macular holes. Please note that by macular hole we are describing full thickness macular holes. The questions which I'll try to answer are: what is a macular hole? What causes a macular hole? How do we diagnose a macular hole? How do we treat a macular hole? And finally, can we predict the outcome of treatment for macular holes? So let's begin with the first question. What is a macular hole? This is the photo of a normal fundus. This central area which has been encircled by the red circle is what we call the macula. Macula helps us get the sharpest vision. It is also responsible for color vision and also allows us to see the small objects. This is how a normal macula looks, and a macular hole is a full thickness hole at the center of the macula, which we also call fovea. So what causes a macular hole? There are various possible causes for a macular hole. For example, blunt trauma to the eye can lead to what we call traumatic macular holes. Patients with high minus power or pathological myopia or high myopia can also develop macular holes. Sometimes there are some diseases which may lead to secondary macular holes like retinal detachment or proliferative diabetic retinopathy. But the most common cause of a macular hole is an idiopathic macular hole, that is a macular hole whose cause is not obvious. It is age related and mostly found in people more than 60 years of age and more common in females than males. For the rest of the discussion, we will not be focusing on traumatic macular holes or secondary macular holes, but limiting ourselves to idiopathic macular holes. So the next question, how do we diagnose a macular hole? The easiest and obvious way to diagnose a macular hole is to check the retina, and sometimes the hole is big enough for us to clearly diagnose that there is a hole, as in these two pictures. The most popular tool or investigation that helps us diagnose a macular hole is optical coherence tomogram or OCT. This is a normal OCT scan, and this you can see there is a full thickness tear or gap and the center, and this is what we call a macular hole. Now, of the two options, that is clinical diagnosis and using OCT to diagnose the macular hole, the OCT is the key, because clinically we can often be misled to diagnose holes where actually there are no holes. For example, in this patient, it seems there is a macular hole here, but we do an OCT and it shows that there is actually no break. So this is what we call a pseudo hole. So something that appears as a hole but is actually not a hole. It is because the epiretinal membrane, which is constricting the retinal surface, sort of causes distortion of the foveal contour so that it appears like a hole, but actually there is none. Here is another patient. Again, there is some epiretinal membrane, but it seems there is a hole. So we think that this probably is actually a genuine macular hole. But we do an OCT and we find that there is actually no full thickness macular hole here. there is only a partial thickness hole. So this is what we call a lamellar macular hole. So it's very easy to misdiagnose pseudo holes or lamellar holes as full thickness macular holes unless we also check the corresponding OCTs. So the next question, how do we treat a macular hole? So the treatment for a macular hole is based on the stage of the macular hole. So let's quickly review the stages of a macular hole. The first stage of a macular hole is when there is an inner retinal split like this. This occurs because of anomalous vitrofoveal traction. So this is vitreous and it is pulling on the fovea, which is the center of the macula. And because of this tangential horizontal pull, it can cause such splitting inside the retina. That is what we call stage 1A macular hole. If this traction persists, as you can see here, this vitreous is still attached to the fovea and it is still pulling, then there may be outer retinal split. So here the retina has almost completely been torn apart, the retinal center, but you can see there is still some retinal tissue which is intact. So this is stage 1B macular hole. As the traction continues to pull on the fovea, then you end up with a full thickness macular hole with persistent vitrofoveal traction, which you can see here. This part of the retina is still being dragged. Here the vitreous is separated from the retina and there is a full thickness hole. So this is stage 2 macular hole. This is also a stage 2 macular hole, but the size of the hole is more here. So the gap has increased, but you can still see there is persistent vitrofoveal traction. Next, this vitreous finally separates from the fovea, but it is still attached to the optic nerve head. So you can see this is the optic nerve head, and you can see here that the vitreous is still attached to the optic nerve head. So this is full thickness macular hole with vitrofoveal separation. This is stage 3 macular hole. This is also a case of stage 3 macular hole. Again, you can see this is the disc. The vitreous is attached to the optic disc, but it is separated from the retina. And this hole is slightly bigger than the previous hole, but this is also a stage 3 macular hole. The last stage is stage 4 macular hole, where you have the vitreous completely separated from the retina. So the vitreous is separated not only from the fovea but also from the optic disc, and that's why in this particular scan we can't see the vitreous, because probably it has collapsed anteriorly and therefore it is not seen in the scan. This also is a stage 4 macular hole, even more old than the previous, older hole than the previous one. So for stage 1 macular hole, whether it is 1A or 1B, the treatment of choice is observation. You do nothing, because half of these patients resolve spontaneously. So this vitreous may simply get detached from the fovea, and then this traction would be gone and the retina can fall back. In stage 2 macular hole, as these two cases, usually vitrectomy is enough. If you have a larger hole, then for example, in this case where there is so minimal separation of the retina, probably just a vitrectomy would be enough. If there is, however, a bigger gap, a bigger size hole, then you may consider doing some internal limiting membrane manipulations. In stage 3 macular hole, usually the holes are larger, like in this case, and therefore vitrectomy alone may not be enough, and you probably also need to do ILM peeling, or in a large hole like this case, a 746 micron separation, you may even have to consider doing an ILM flap. What are ILM peeling, ILM flap, and all those techniques we will discuss in a subsequent presentation. In stage 4 macular hole, where there is absolute vitreous separation and usually the holes are quite large in size, usually we not only have to do PPV and internal limiting membrane techniques, manipulation like internal limiting membrane flaps or making multiple flaps to stuff the hole. Sometimes if the holes are more than 1000 micron, we may even have to consider doing autologous retinal grafting or amniotic membrane transplant. So that brings us to the last question. Can we predict the outcome of treatment for macular hole? So from stage 2 macular hole onwards, we basically treat and the treatment is surgery. There was a suggestion that in stage 2 macular hole, there may be some drugs which can induce vitreous separation like ochriplasmin, and you can try them to close the macular hole in a non-surgical manner, but ochriplasmin never really became popular and anyway it is not available in India. So for us, practically we don't treat in stage 1, but stage 2 onwards we do surgery. So whenever we do suggest a patient a surgery, naturally the patient would want to know how likely it is that my hole will close, and more importantly, will I get back my lost vision? Will I regain vision? So how do we answer that question? So the two factors that can help us answer that question are: one, the stage of the hole, and two, the size of the hole. For example, here are two cases. Now, between these two patients, if you see, the holes appear more or less of the same size, but you can see here there is persistent vitreofoveal traction. So this is stage 2, but we can't see the vitreous here. So either this is stage 3 or stage 4 macular hole. So this has a lower staging than this hole. And between the two, therefore, it is the hole on the left hand side which is likely to have a better prognosis. It is more likely to close and visual recovery chances are more in this hole. So the lesser staged holes always have better outcomes. Now here are two cases. In both these cases we can see the vitreous and we can see it is separated from the retina, but it is attached to the optic nerve head. You can see here it is attached to the optic nerve head, it is attached to the optic nerve head in this eye also. So these are two stage 3 macular holes. One is only 135 micron big, the other is 766 micron big. So when you have two holes of the same size, the smaller hole is the one which is more likely to close down and also more likely to regain vision. So the smaller the hole, the better it is, provided the staging is same for the holes that you are comparing. So here are a few tips. Now you can look out for certain subtle signs on the OCT scan, based on which you can easily tell your patient what is the likely prognosis, how likely is the hole to close, and how much chances of recovery of vision is there. So patient who has a persistent vitreofoveal traction, that means it is stage 2, you can tell them clearly that you are more likely to close, you are more likely to gain vision. So if you have a persistent vitreofoveal traction like this, you can tell the patient that's a positive sign. I like to operate on you as fast as possible because you are more likely to close and also gain vision. Presence of intraretinal cyst, this kind of cystic changes, this is also a positive sign. For example, you see this hole, there is hardly any cystic changes at the edges. So this is a sign of chronicity. The more fresh the hole, the more the fluid will be there in it. And the more the fluid at the edges, the greater the chances of the hole actually closing successfully with recovery of vision. And the third is what we call the drawbridge sign. The drawbridge sign is the edges, if they are lifted up like this, if they are lifted up from the retina, up and away, that means that this macular hole is having higher chances of closing after surgery. But if the edges are turned down like this, it's almost as if the edge has got stuck to the RPE. So these are the cases where it's very unlikely for us to achieve any significant difference even if we operate, because this hole is probably has anyway the edges have got stuck, they will probably not come closer. So presence of vitrophobial, persistent vitrophobial traction, cystic changes in the edges, presence of fluid at the edges, or a drawbridge configuration of the edge are all positive prognostic factors which increase the chances of the hole closing and vision recovery. So with that, we have come to almost the end of today's discussion. Before ending, here is a quiz for everyone. So this is a person, Mr. AD, a 64-year-old male, who has now come to us with a macular hole in both eyes. So if you look at these OCTs, and let me just read these small figures. This is 618 micron sized hole, and this is a 366 micron sized hole. So the question is, between the right and left eye, which eye should I or should you operate first? So do let me know what is your opinion through the comments. And in the next class on macular holes, where we will be sharing with you videos of how we actually do the surgery, what is, how the vitrectomy is done, how vitreous is removed, what is ILM peeling, how ILM flaps are made, all those videos we'll share in the next class. So in that lecture, we will definitely answer or share the answer to this question also. But till that time, please do let me know what you think about this class and the answer to this question through the comments. Thank you so much.